Usually when you talk about a surgical procedure, there's this comforting expectation of absolute precision.
Right, yeah. It feels a lot like engineering.
Exactly. Like if a patient comes in with a complex facial fracture, the X-ray shows you exactly where the bone fragments are. You can point at the screen and just confidently say, there's the problem, and here's exactly how we fix it.
Because the physical anatomy rarely lies to you. I mean, the fracture is either there or it isn't. The margins of a tumor are either clear or they're involved.
Yeah, it's very structural, but the moment you step out of the operating theater and into the world of medical ethics and law, that X-ray machine becomes completely
Oh,
useless.
entirely useless. Yeah.
Suddenly you're navigating a landscape that is just incredibly murky. You're no longer just dealing with tissue and bone. You're dealing with human autonomy, legal precedent, moral philosophy.
And that can be terrifying for a surgeon.
Totally. And for anyone practicing medicine, especially if you are a surgical resident furious prepping for your FRCS board exams, understanding this landscape is just as critical as knowing your anatomy.
Absolutely. It's life or death in a totally different way.
So today on the deep dive, our mission is to rapidly but thoroughly unpack the foundational rules of medical ethics and law. We're getting right to the point. We're going to use a question and explanation style to look at the real-world tightropes doctors walk every single day.
Because we need to understand the fundamental mechanics here. Like, why can a patient legally refuse life-saving treatment? Or what is the exact threshold where an accepted medical practice suddenly becomes criminal negligence?
Right, high stakes. So let's unpack this from the very beginning. Before we even touch modern legislation, we have to look at the philosophical bedrock.
Yeah, the origins of all this.
Right, because ethics isn't just this vague feeling of, wanting to be a good person. The word itself comes from the Greek ethos, meaning custom or character. And the codes governing us today, they didn't just appear out of nowhere.
No, they were forged in response to some really dark history.
Exactly. Everyone references the ancient Hippocratic Oath, but the modern standards were essentially born in the aftermath of the Second World War.
The turning point was absolute necessity. Following the medical crimes committed in Nazi Germany, the World Medical Association adopted the Geneva Declaration in 1948.
Which was basically a modernization of the Hippocratic Oath, right?
Exactly. It was a direct response to ensure those specific atrocities could never be replicated under the guise of medicine again. And then that was followed by the Helsinki Declaration in 1964.
And Helsinki specifically governs human experimentation, right? Incorporating the Nuremberg Code.
Yes. It sets incredibly strict boundaries for clinical trials.
All right, let's unpack this with a specific example, because the rules around clinical trials are fascinating. Like, say you're doing a trial on a new treatment for melanoma.
Okay, classic scenario.
The control group must receive the current standard of care treatment. You cannot just put a melanoma patient into a no-treatment placebo group just to get cleaner statistical data for your new drug. It's explicitly unethical.
Right, because the underlying logic there is the absolute paramountcy of the individual patient.
The person right in front of you.
Exactly. If an effective standard treatment exists, withholding it for the sake of an experiment violates your core duty. You can't sacrifice the health of the human being sitting in front of you today on the altar of potential statistical breakthroughs for tomorrow.
The individual's right to care always supersedes the scientific inquiry.
Always.
Which flows perfectly into the actual tools we use to navigate these daily decisions. The 4 principles of medical ethics from Beauchamp and Childress.
The big 4. We evaluate almost every dilemma through these lenses.
Right. So first, autonomy. The patient's fundamental right to self-determination. Second is non-maleficence. First, do no harm. Third, beneficence, the active obligation to do good. And fourth, justice, dealing with fairness and allocating limited resources.
And those sound wonderfully harmonious in theory.
In a textbook, sure.
But in practice, on the ward, they constantly collide. The real test is what you do when these principles are in direct opposition.
Let's look at the classic clinical collision. A Jehovah's Witness who is hemorrhaging and desperately needs a blood transfusion to survive.
A very real, very difficult situation.
Right, because as a surgeon, your principle of beneficence is just screaming at you to administer the blood. That is the objective medical good.
But autonomy dictates that if this is a competent adult, they have the supreme right to refuse it, even if that refusal guarantees their death.
So how do you reconcile that?
Well, if we connect this to the bigger picture, it forces the physician to redefine what good actually means. To the surgeon, Biological survival is the ultimate good.
Sure, obviously.
But to the Jehovah's Witness, receiving that blood might represent profound spiritual destruction. They consider that a fate literally worse than physical death.
Wow, so forcing it on them is actually doing harm in their eyes.
Exactly. The old paternalistic era, where the doctor just decides what's best and forces it, that's entirely dead. Withholding the blood is, paradoxically, the truest way to respect their concept of what is good. Autonomy almost always holds the trump card.
But what happens when we face a total gridlock? Like, when you have to choose between patients, we have to rely on broader ethical frameworks, right? Utilitarianism and deontology.
The two heavyweights of moral philosophy.
Yeah. So utilitarianism is essentially a numbers game, the greatest good for the greatest number. While deontology argues that certain actions are just intrinsically right or wrong, regardless of the math,
Right.
there's this highly relatable analogy. If a friend asks you, does my bum look big in this outfit? And you know it does.
A dangerous question.
Very. If you lie and say no to protect their feelings and avoid ruining the evening, you're acting as a utilitarian, prioritizing the positive outcome over strict truth.
But if you say yes, you're a deontologist. Telling the truth is fundamentally right, even if it causes immediate pain.
But let's escalate that framework to the most extreme medical scenario possible.
Okay, the organ harvesting thought experiment.
Yeah. You have 5 patients in the ICU, all dying from different organ failures. In your waiting room, you have one perfectly healthy patient.
Pure utilitarianism, taken to its absolute mathematical extreme, could technically justify killing that healthy patient to harvest their organs and save the 5.
Which is horrifying.
It is. The math works 5 lives for 1. But that visceral horror you feel, that is deontology kicking in.
Because murder is an absolute wrong.
Exactly. Under deontology, killing an innocent person is intrinsically wrong. It doesn't matter if the math yields a net positive of 4 surviving humans. The mechanism murder is fundamentally unethical.
And we see this tension with resource allocation, right? Like, not spending massive resources on a 90-year-old with severe dementia and 70% burns, because those resources could save multiple younger patients.
Utilitarianism suggests prioritizing the younger patients. But deontology forces us to recognize the intrinsic value of that 90-year-old's life. It keeps the pure clinical mathematics from stripping away our humanity.
Let's shift from the philosophical debate into hard courtroom reality. Because while autonomy is a great philosophical concept, a surgeon needs to know exactly how it's defined under the law to avoid, say, a battery charge.
Yes, getting into the actual legislation now.
Under the Mental Health Act of 2008, valid consent has to meet 3 strict criteria: voluntary, informed, and competent.
And capacity is the linchpin there, defined strictly by the Mental Capacity Act of 2005.
Right, they have to understand the info, retain it, weigh it, and communicate a decision.
Exactly those 4 steps.
But here's what I want to ask. Let's say a patient clearly meets all 4 criteria. They understand the risks, they're communicating clearly, but they're making a genuinely terrible, completely irrational decision that will lead to severe harm. Can a doctor step in and override it?
The law is incredibly clear on this. The answer is an absolute no.
Really, no leeway at all.
None. This was famously cemented by Lord Donaldson in the Reti case of 1992. He ruled that a competent adult has an absolute unassailable right to refuse medical treatment.
Even if the reasons make no sense.
That's the most crucial part of his ruling. A competent adult can refuse for reasons that are rational, irrational, unknown, or even completely non-existent.
That is a staggering legal precedent. The law actively protects a patient's right to be entirely irrational.
It does. The Mental Capacity Act explicitly states a person cannot be treated as lacking capacity merely because they make an unwise decision.
Because otherwise doctors would just label anything they disagree with as irrational.
Precisely. It would be a backdoor to the old paternalism. True autonomy means having the freedom to make catastrophic mistakes.
There's also a geographic nuance to the informed part of consent.
Oh, definitely. It varies wildly.
Like in the US, Canada, or Australia, they rely on the prudent patient test. What would a reasonable patient want to know? But in England and Wales, based on the Sit-Away case of 1985, it historically leaned more toward the standard of disclosure. What would a responsible doctor disclose?
Right. It leans a bit more toward the doctor's judgment historically, but the landscape changes completely when the patient isn't an adult.
Minors. Yeah, the concept of absolute autonomy really fractures here. Under the Family Law Reform Act of 1969, the legal age for medical consent in the UK is 16.
But children under 16 frequently need medical treatment, and they can sometimes consent if they achieve Gillick competence.
The origin of Gillick competence is a fascinating piece of social history. 1974, Victoria Gillick.
Yes, a mother of 5 daughters, all under 16.
She was absolutely furious about a government circular allowing doctors to give contraceptive advice to under 16s without parental consent. She fought it all the way to the House of Lords.
And she lost. Lord Fraser delivered the pivotal judgment, establishing that parental rights yield to the child's right to make their own decisions, once the child reaches sufficient understanding and intelligence.
Right, which we now call Gillick competence, though sometimes people call it Fraser competence, which is technically a misnomer, right?
Yeah, please don't use Fraser competence on your exams.
Yes.
It's Gillick competence.
But here's where it gets really interesting for clinical practice. Gillick competence is situation-specific. An 8-year-old might be competent to consent to a minor nail bed repair under local anesthetic.
Because they understand a needle hurts and it will fix their finger.
Exactly. But that same 8-year-old absolutely cannot consent to a heart transplant.
The sheer gravity and long-term ramifications require a cognitive threshold an 8-year-old just doesn't possess.
And this creates a really crucial legal asymmetry. If a Gillick-competent minor says yes to a proposed treatment, that consent is legally valid. It overrides the parents completely.
The parents can scream and shout, but the doctor can proceed.
But the reverse isn't true, is it?
No, this is what's fascinating here. If that same competent minor explicitly refuses a life-saving treatment, a parent or a court can still step in and override the child's refusal.
If it's in their best interests.
Exactly. The law prioritizes the child's survival over their developing autonomy. They have the power to consent to save their own life, but not the power to refuse life-saving treatment if a parent demands it.
That is absolutely vital for the boards. So, moving on. What happens when surgery goes wrong, when consent wasn't established or a mistake happens? We have battery and negligence.
2 very distinct legal threats.
Battery is a trespass against the person, intentionally bringing about harmful contact without valid consent. Like, you have consent to amputate the left leg and you accidentally amputate the right.
That is battery. You had 0 consent to touch the right leg.
But negligence is different. It's a breach of duty of care resulting in damage, like you operated on the correct leg, but you failed to disclose a major risk of nerve damage.
And the entire history of medical negligence hinges on how courts define that breach of duty. For decades, it was defined by the Bolam case in 1954.
John Hector Bolam. He was undergoing electroconvulsive therapy, ECT, for depression, and they didn't give him a muscle relaxant.
The physical force of his own seizing muscles was so violent that it literally fractured and dislocated both of his hips.
Bilateral hip fractures. And he sued, obviously.
But he lost. The judge ruled the doctor wasn't negligent because at the time, medical opinion was divided on using relaxants. The doctor showed he acted in accordance with a practice accepted by a responsible body of medical opinion.
The famous Bolam test.
What is done by your peers?
But wait, objectively, that sounds incredibly problematic. It essentially means as long as a doctor can find a handful of colleagues to say, yeah, we also do it that way, they can't be sued.
It was a massive shield for the medical profession, a very dangerous loophole.
Doctors protecting doctors.
Exactly. And the law finally closed that loophole in 1997 with the Bolitho case. A tragic case involving a 2-year-old boy who suffered cardiac arrest and brain damage because a pediatric registrar failed to attend him after being bleeped twice.
And her defense was that even if she had attended, she wouldn't have intubated him anyway. And under the old Bolam test, she just found experts to agree with her.
She did find a distinguished body of experts who said they wouldn't have intubated either. Under Bolam, she's cleared.
But it went to the House of Lords.
And Lord Brown Wilkinson shifted the entire paradigm. He stated that simply finding experts to agree is no longer enough. The court itself must be satisfied that the expert opinion has a logical basis.
The opinion must withstand logical analysis and weigh comparative risks. It changed the standard from what is done to what ought to be done.
Precisely. The judges basically took back the power to decide what is logical from the medical profession.
Wow. Okay, so beyond the operating theater in the House of Lords, plastic surgeons face a daily minefield of administrative traps. Let's do a rapid-fire legal quiz for you based on the texts.
I'm ready. Let's do it.
Scenario A. You're on a night shift. Police walk onto the ward demanding the confidential medical records of a patient you just treated.
Generally, you must refuse. Police have no automatic right to patient info. However, if it's a gunshot wound, you have a mandatory duty to report it, even if the patient says it was accidental.
What if it's a stab wound?
If you are clinically satisfied the stab wound is accidental or self-inflicted, you shouldn't report it. The nuance of the injury dictates the duty.
All right, scenario B, medical photography. You get an incredible outcome on a facial reconstruction, and you want to use the photo for a conference. Can you just put a black bar over the patient's eyes to anonymize it?
Absolutely not. Simply blacking out the eyes does not replace the requirement for explicit informed consent.
And who owns the copyright to that photo? The patient.
Surprisingly, no. Legally, under the Copyright Act of 1988, the copyright belongs to the photographer or the hospital employing them, but you still can't use it without the patient's consent.
Got it. Okay, scenario C. A severed finger in the clinic fridge. Patient comes in with a traumatic amputation. You put the finger in the fridge while prepping theater. What dictates how you handle that tissue?
The Human Tissue Act of 2004. If you store that amputated part, or say skin autographs, for under 48 hours, you don't need an HTA license.
But what if it sits there for 48 hours and 1 minute?
You cross a major legal threshold. Over 48 hours requires a specific HTA storage license, and it triggers mandatory virology testing for the donor HIV, hepatitis B and C, syphilis.
The clock is ticking the second it goes in the fridge.
Yeah, exactly.
And overseeing all this data and tissue tracking, we have Caldecott Guardians, right?
Yes, every NHS organization must have one. Their mandate is protecting patient data on a strict, need-to-know basis.
And combining that with the Children Act in 1989, the paramountcy principle, where a child's welfare is the paramount consideration, you realize just how dense this legal safety net really is.
We have covered an immense amount of ground today, from ancient Greek origins to the hyper-specific legalities of tissue storage and the belythological analysis test.
We really have. So congratulations to you listening for surviving this rapid-fire revision deep dive. But before we wrap up, I think there's a really fascinating paradox here to leave you with.
There really is. We've seen that the law heavily protects an adult's absolute right to make a completely irrational decision to refuse treatment, all under the banner of autonomy.
Right. But at the same time, under the Beletho test, the law demands that doctors' decisions be purely, flawlessly logical.
Exactly. And it leaves us with this provocative thought. As medical technology continues to advance and AI becomes deeply integrated into predicting surgical outcomes, will we reach a point where a patient's legally protected irrational autonomy is challenged by courts demanding logical, mathematically optimized outcomes for everyone?
It's a stunning double standard to think about. What stands out to you from today's deep dive? Did learning about Gillick competence or the Beletho ruling change how you view your next hospital visit or shift?
We'd love to hear your thoughts.
Absolutely. Leave a comment or a question for us wherever you are listening. And if you are prepping for the FRCS plastic surgery exams, head to medsynclimited.com. You can get the FRCS plastic surgery Enki deck there. It has over 6,000 questions arranged by topic to help you rapidly recall these key facts, and it's heavily based on the textbook Keynotes in Plastic Surgery.
It's an incredible resource for locking this in.
Be direct, don't waste time. So make sure to hit follow so you don't miss our next deep dive, and please rate the show if you learned something new today. See you next time.